Good morning, everyone. I'm Stephanie Imane, and I'm a clinical research assistant at the Massachusetts General Hospital, working in the pediatric epilepsy department in the Dup15Q clinic under the direction of Dr. Ronald Thiebert. And then I just wanted to do a quick thank you to the Alliance for their continuous efforts in patient and research advocacy. At the Dup15Q clinic at Mass General Hospital, we've seen 116 Dup15 patients whose charts were retrospectively analyzed in order to characterize myoclonus in the Dup15 population. Some of the common symptomatic manifestations of this syndrome are listed here, mainly being neurological and psychological, like autism, anxiety, and other mood disorders. As you're probably familiar with at this point, this is one of the subtypes, which is interstitial duplications, and triplications, which we'll hear more about. And then isodicentric, which occurs in two forms as well, which is shown here. Among the molecular genetic subtypes that we've seen in our clinic at Mass General, IDIC resulted with the highest prevalence at a rate of 62%. So as you can see, there's 72 individuals who've presented out of the 116 with IDIC diagnoses. And this graph showcases the seizures observed in our clinic by seizure type, though individuals do experience multiple seizure types throughout their lifespan. And in this presentation, I'm focusing on myoclonus, both in the epileptic and non-epileptic form. So epileptic myoclonus, alias myoclonic seizures, are characterized by epileptiform EEG changes, which can be identified as brief episodes or prolonged myoclonic status of generalized spike and wave activity. And non-epileptic myoclonus is void of EEG correlates in comparison to myoclonic seizures that are associated with the epileptic changes and altered states of consciousness. Non-epileptic myoclonus can present differently in individuals with respect to onset, frequency, duration, and exacerbating factors. Episodes have a discrete beginning and end and have no post-ictal period. These episodes can prove challenging when navigating recourse treatment, as many individuals are often refractory, or many of these episodes are refractory to prescription alleviation. And although non-epileptic myoclonus does not incite regression, it can significantly impact one's quality of life across all clinical domains. So through observational clinical research in the Dup15 population at our clinic, myoclonus in both forms occurs on average in 19% of individuals who presented to us at our clinic in Boston. And non-epileptic myoclonus occurred in 12%, whereas epileptic myoclonus occurred in 9%. And 3 individuals who presented with both epileptic and non-epileptic myoclonus. So in our other clinics at Mass General Hospital, we found that myoclonus is present in similar neurogenetic syndromes within chromosomal range, like Angelman syndrome and Pitt-Hopkins. At our Angelman syndrome clinic, we've seen about 300 patients, and non-epileptic myoclonus is present in about 19% of those individuals, while myoclonic seizures are present in 14% of individuals. And in our Pitt-Hopkins population, where we've seen about 70 patients, non-epileptic myoclonus was present in 15%, whereas only 1 individual presented with myoclonic seizures. And clinical observations in these populations exhibited the presence of myoclonus in both forms is worsened by disordered sleep, GI dysfunction, anxiety, or excitement, with psychosis, mood disorders, and anxiety being the most intense exacerbating factors within this population of Dup15 patients. So treatment of myoclonus differs depending on the type that an individual is experiencing and the individual themselves. And so for non-epileptic myoclonus, the main treatment is alleviating the symptoms of the comorbidities associated with this syndrome. So the severity of NEMC is reportedly decreased once the symptoms of GI or anxiety have been alleviated. And if resolving these symptoms of the secondary conditions is not effective in treating NEMC, and the events are severely impacting an individual's quality of life, prescription benzodiazepines within the Keppra family have been effective in controlling these episodes, although they are, as I've said, refractory to medication at times. Recourse treatment for epileptic myoclonus, however, lies solely on the prescription of benzodiazepines of the same family, Keppra, and dietary therapy as well. Although secondary conditions left untreated will exacerbate the frequency and severity of myoclonic seizures in this population. And I just want to say thank you to all the families who've come to see us in Boston at the Massachusetts General Hospital and the Lurie Center, and thank you for having me today.
Hi, good morning. I'm Kim. I serve as the Clinical Research Manager at the Massachusetts General Hospital in the Pediatric Epilepsy Dup15q Clinic under the direction of Dr. Ronald Lieber. A big thank you to the Alliance for having Mass General present their continued research efforts, patient advocacy, and cultivating a community for families. At the Dup15q Clinic at Mass General, we have seen 116 Dup15q patients whose charts were retrospectively reviewed to assess the Dup15q patient population. What is an interstitial triplication? An interstitial triplication is when duplicated genetic material of chromosome 15 is included within the long arm of one of the two copies of chromosome 15 in comparison to an extra chromosome. Like that of isodicentric 15. Here we see two variations of the copy, one symmetric or inverted copy and the other asymmetric. The duplicated segment of the interstitial triplication is usually adjacent to the normal copy and can be oriented in the same direction or inverted. Of the 116 Dup patients we have seen at Mass General, 9 are interstitial triplications that make up about 7% of our Dup patient population. We found that individuals with interstitial triplications have similar clinical manifestations like that of IDIC-15, however less severe and less frequent. Of the 9 patients with interstitial triplications, the following results were found. Psychological clinical manifestations were found to have the highest prevalence, 4 reported anxiety, 7 confirmed autism diagnoses, 1 confirmed ADHD diagnosis, and 1 OCD diagnosis. For GI, 3 reported constipation, 2 reported reflux and GERD, 1 reported irritable bowel syndrome, and 1 reported colitis. 2 reported sleep disturbances and sleep apnea. Of the 9 interstitial triplications, 3 had epilepsy. The following was reported early childhood epilepsy, myoclonic epileptic myoclonus. Tonic-clonic was reported as a first clinical seizure, tonic-clonic to tonic seizure. Likely had focal onset seizures when younger, intractable symptomatic generalized, and symptomatic generalized epilepsy and epileptic encephalopathy, atonic and tonic seizures. Upon reviewing and assessing patient data, it was evident that interstitial triplication clinical manifestations are less severe and frequent when compared to that of isodicentric 15. We are continuing our research efforts to further understand the differences among isodicentric and interstitial genotypes and phenotypes. We are further investigating interstitial genetic material that expresses in succession in comparison to isodicentric patients that have an additional chromosome. Additionally, we are looking into genes outside of breakpoints 3 versus 4 and 5 and how they behave with other surrounding genes, and the possibility of mosaic diagnoses that were previously undetected. Thank you.